Yeah, so we will start with Dr. Shalini Mohan. Okay, great.
Thank you so much. Thank you so much, Dr. Reena. And so I will be talking about pearls in history and examination. So we know we all take very detailed history and examination for our patients, but then sometimes we tend to miss something because we might be busy or something which is not in our minds. So whenever we are taking history, we do take history of brow ache or hemicranial headache. Sometimes history of frequent change of reading glasses is another important thing which we should be taking in patients of glaucoma. Now, a family history, we know that it's very, very important to take in all the patients of glaucoma. But there are certain things which we always should ask, especially steroid in any form, even if it is an ointment form which is being used. Sometimes even if patient is using some other allied medicine, maybe homeopathic or Ayurvedic medicine, which might be having steroid. Then trauma, uveitis, sleep apnea is another important factor which might be there in the patients who are progressing with glaucoma despite control of intraocular pressure. So there can be severe blood loss or any intracranial disease which might be giving us clue about secondary glaucomas. Now, another important thing which I actually wanted to highlight was use of systemic medications that may impact our glaucoma management. Now, let's see this particular female who was a 50-year-old female who was diagnosed with glaucoma 1 year ago elsewhere. So, she was doing well on one prostaglandin analog by putting at bedtime. There was no previous history of any ocular trauma or procedure. But there was past history of hypertension and she was on medication. There was no family history also. But the problem was that in recent follow-up, a visual field defect was evident in that lady, and that is why patient was referred to us, because this visual field defect appeared despite controlled intraocular pressure. So we did a detailed examination, and the vision was 6/6 in both the eyes. And this was the gonioscopic picture. We can see wide open angles in both the eyes. Central corneal thickness was normal, 543 and 539 in both the eyes. Now, when we checked intraocular pressure, it was also pretty well controlled, not that bad. Right eye was having 18 millimeters of mercury with the diurnal variation of 14 to 20 millimeters of mercury, and left eye was 16 and variation was 12 to 18 millimeters of mercury. Now, these were the disc picture. We can see the superior notch in the right eye and superior and inferior notch in the left eye with 0.8 cup disc ratio. Now, this was the visual field. Right eye almost normal, but left eye showed a inferior arcuate scotoma. So the question was that if the patient was controlled on intraocular pressure, why at all did this patient was showing this scotoma? So then we went back and we again thought, are we missing something? We examined, we asked the history of snoring, because we know that sleep apnea has been associated with progression of glaucoma. Because she was a hypertensive patient, therefore a 24-hour blood pressure monitoring was done for this particular female, and it was very noticeable that nocturnal hypotension, that is a blood pressure of almost 170/56 was seen at early in the morning around 4 a.m. So we know that nocturnal hypertension is associated with risk of glaucoma progression because of reduced diastolic perfusion pressure, and therefore we had a talk with internist of the patient, and the antihypertensive medication was adjusted so that this hypertension is not evident, and then patient did well. So the thing is that there are so many medications which patient is taking. So history of these medications is very, very important because they might actually impact the glaucoma management. Now, this is a very nice study which was published in Survey, and this was glaucoma and systemic disease. And now in this, it was seen that hypertension is the most common association, followed by hypercholesterolemia and diabetes, and then the cardiac disease. disease. Now, the common medication which the patients were using were antihypertensives, followed by antiplatelets and anticoagulants, and then antihyperlipidemic agents. Now, when we are talking about blood pressure, I already talked about obstructive sleep apnea. Now, this was seen in Baltimore Eye Survey and Igna-Newmark study also, that there is an inverse relationship between diastolic perfusion pressure and progression of glaucoma. Similarly, if patient is taking antihypertensive, suppose he is on beta blocker, so oral beta blockers, they interact with topical beta blockers, so we tend to avoid giving topical beta blockers in the patients who are already using oral beta blockers. We also should understand that if patient is on thiazide diuretic or any loop diuretic, then it might lead to for the acute primary angle closure glaucoma due to anterior shift of lens iris diaphragm. So sometimes patient might present, and there are anecdotal case reports which tell that there was an attack of acute primary angle closure glaucoma. Then, diuresis can be induced if there is concurrent use of carbonic anhydrase inhibitors. So, especially in elderly male, we need to be careful whenever we are prescribing this drug. Now, we know that peripheral calcium channel blocker are preferred in glaucoma patients, so that can be an added benefit. Now, when we talk about various cardiac drugs like anticoagulants, aspirin we know is very commonly used these days, but it has been reported that secondary angle closure glaucoma can be due to a use of aspirin. Shall I continue? Yeah. So, there was a case report of a non-ophthalmic patient which had bilateral angle closure glaucoma with warfarin. So, the thing is that whenever patients are using these medication, we should be careful about secondary angle closure glaucoma which might be having in these patients. Now, coming to diabetes, we know its role is not very well established because sometimes it has been found to be associated with increased incidence of glaucoma. But the neovascular glaucoma is one entity which we all should be understanding and should be careful in the patients who are having uncontrolled diabetes or having proliferative diabetic retinopathy. Now, whenever we are talking about these anti-hypoglycemic drugs, we should be careful because adrenergic agonist, which we are using, can decrease the effect of insulin and may induce hyperglycemia. So, suppose if the patient, you are prescribing some brimonidine kind of thing, then you should be careful about the effect of insulin. Then in systemic carbonic anhydrase inhibitors, if patient is using, it can lead to hypokalemia due to increased blood sugar level in diabetic patients. So, you should be careful in critically ill patients. Similarly, glycerol we all know we have to avoid in diabetic patients. Now, after these systemic medication, I am coming to another case of a 22-year-old female. She was using spectacles for past 12 years and one day she had some headache and she was prescribed some medication. But then she had sudden loss of vision with headache, nausea and vomiting. This was the history she was giving. So on examination, the best corrected visual acuity was hand movement in both the eyes. She was severely photophobic, just unable to open the eyes. So when we took this girl of 22-year-old to slit lamp, this was the picture of anterior chamber depth. The anterior chamber were extremely shallow in both the eyes with circumciliary congestion. There was significant corneal edema and both the pupils were mid-dilated. Now, when we checked the intraocular pressure, it was 43 and 48 millimeters of mercury. So, obviously, this was the clear-cut case of bilateral acute angle closure glaucoma. So, we know that whenever there is bilateral acute angle closure glaucoma, it cannot be actually idiopathic generally, but it is secondary to some or other medication most of the times. So, what course of action we have to do? Again, we have to focus on retrospective history and all causes of bilateral acute angle closure glaucoma. So, in this particular girl, she took topiramate for migraine and therefore she had this acute attack of angle closure glaucoma. So, these are various antidepressants and anticholinergic which can lead to this kind of problem. You can get this list anywhere on net or any book. So, the thing is that we have to be very, very careful whenever we are prescribing this drug. So, anterior segment imaging like UBM is diagnostic in such a scenario. scenario. We can see there is a cleft over here, and if you do ultrasound, B-scan ultrasound using water bath, you can again localize this. So the management, obviously we have to stop the drug. We have to add systemic and oral anti-glaucoma medication, and obviously the topical medication, avoiding prostaglandin analog because this is an inflamed eye. Therefore beta blockers, alpha agonists and carbonic anhydrase inhibitors are to be added. It is always mandatory to add topical steroid in such a scenario because of increased inflammation. Now here we have to add cycloplegic to relax the ciliary body because there is already a effusion, ciliary body effusion, so we want to reduce that. But we don't give pilocarpine in such a scenario, and no laser iridotomy is to be done in such cases of secondary acute angle closure glaucoma. So now coming to another few important points which we have to look in patients with secondary glaucoma. Now whenever we are doing this comprehensive eye examination, certain things like visual acuity and refraction we all do. Now let's go one by one to them. In visual acuity, it is very important to examine projection of rays, because we know that in patients of glaucoma, despite having good visual acuity, patient might be having defective projection of rays. Now these are the few cardinal measurements which we all do in all patients of glaucoma. Applanation tonometry is the gold standard. Gonioscopy we have to do for all our glaucoma patients with dilated disc examination, and of course the visual field examination. But it is important to give few extra seconds to torchlight examination. Don't forget using torchlight, because sometimes this diffuse light examination might give you some important clues. Like in this girl, you can see there is a nevus, conjunctival nevus, very classically seen in nevus of Ota. And the small baby, you can see there is a port wine stain on both the side of forehead. So here we can see this port wine stain here and here. So we know it is associated with Sturge-Weber syndrome. So these kind of capillary hemangioma, if you can miss if you are directly see the patient on the slit lamp. So do a bit of torchlight examination, and then of course you have to see RAPD in the patients with the help of your torchlight examination. So that is another important thing which we should not miss. Then coming to slit lamp examination, of course circumciliary congestion you all see, but sometimes in the second photograph you can see these kind of dilated episcleral vein. So we know that these type of dilated episcleral vein might be associated with raised intraocular pressure due to increase in episcleral venous pressure. So in such cases we should be careful. Now coming to another important thing which we sometimes don't do. Suppose patient is sitting on the slit lamp, don't forget to elevate the eyelid, because certain times there might be hidden clue beneath the eyelid which we tend to miss if we do not. Like a small YAG iridotomy like this might be there which is hiding beneath the eyelids, or you might be seeing a small bleb beneath the eyelids. If you don't elevate, you tend to miss. Now coming to cornea. Now it is important to examine detailed examination of cornea. Like here we can see a Krukenberg spindle indicating pigmentary glaucoma. Here you can see mutton fat KP signifying uveitic glaucoma, and here you can see tram track appearance in ophthalmic eye. Now here also you can see this is a scar which has thinned out. Now thinning of corneal scar is very much evident in the patients with viral keratouveitis, which can lead to secondary glaucoma. So you have to make note of this particular finding, and obviously you tend to check the corneal sensitivity also. Then next coming to pupillary margin, which is something very good to give us clue about secondary glaucoma diagnosis. Like this, you might be having a pupillary ruff which is hypertrophic, or you might be having these white powdery deposits in the patients of pseudoexfoliation glaucoma, or you might be having these kind of pupillary ruff where you can see broken ruff in the cases of traumatic glaucoma. And then of course neovascularization at the pupillary margin, which is first to appear in the cases of neovascular glaucoma. Now, another thing is that whenever you have a very, very busy practice and you are just unable to do gonioscopy in all the patients, this Van Herrick's test is very, very good screening modality for your glaucoma, for your patients in busy OPD. And then once you have done the ACD and you find that it is shallow, then you have to do gonioscopy for all your patients. Gonioscopy we will be discussing in detail, and then of course you have to do dilated pupillary examination and look for certain posterior synechia. Don't forget to do retroillumination, as you can see here, and then you can see these thinned out iris areas in the cases of pigmentary glaucoma. Sometimes these kind of iris atrophic patches are very, very important, and you can see it is pulling the pupil towards it, signifying previous attack of subacute angle closure glaucoma or maybe any viral keratouveitic glaucoma. So these things we have to make sure that we don't tend to miss, despite the fact that they might be smaller subtle findings. We all know that this kind of picture, if we see, we should be careful about pseudoexfoliative glaucoma and weaker zonules. And then, of course, these are the areas where we can see the phacolytic glaucoma. Now, you can see these kind of glaucoma flecken in the cases of previous attack of acute angle closure glaucoma, or you might be seeing a washes ring like this in the cases of post-traumatic glaucoma. So then you can have a subluxated lens. So always dilate the pupil if it is indicated or angle is not shallow. Always dilate and examine the lens of the patient also. Now coming to disc examination, where disc we all know how to do, where we use any lens you are comfortable with, any 90D or 72D lens. But then of course you have to apply the correction factor to get the exact size of the disc. The intraocular pressure, we all know, applanation Goldman tonometry is a gold standard. But one thing which I actually have seen that sometimes people are using NCT, which should not be used. But in rebound tonometer is a good modality, especially in cases of scarred cornea or in pediatric glaucoma, where you can get good readings from rebound tonometer. So to summarize, I would say that we should be very careful whenever we are examining our glaucoma patients, especially secondary glaucoma and NTG patients. If glaucoma is progressing despite normal intraocular pressure, we need to look at certain things which are, we need to think out of the box, like for sleep apnea or atrial fibrillation or vasospastic disorder or hypotension. We can do 24-hour blood pressure monitoring whenever required in conjunction with a physician. Then we also need to monitor various medication which the patient is taking other than anti-glaucoma medication to avoid any systemic side effect. And then of course comprehensive examination is key to successful diagnosis. Thank you so much for your kind attention.
Thank you, Dr. Shalini. I think she's very nicely covered all the points in history taking, and I think this course actually was meant to highlight how to avoid misdiagnosis of glaucoma. So when we talk of misdiagnosis, we are talking of two things. One, we want to pick up glaucoma when there is. Second, we don't want to miss a case of glaucoma or overdiagnose it. And also we need to pick up if we are treating a patient but the patient continues to progress. And I think the role of everything from history taking to evaluation to investigations, the points that we wanted to make actually in today's session was to see how we can avoid doing that, how we can find a ideal management profile for every patient. And some patients can have glaucomatous optic neuropathy, which might be burnt out, which means that they might have had a trauma, might have had transient or few months high intraocular pressure leading to an optic neuropathy, but now it is stable, might not need treatment, or a patient might have had a hypertensive uveitis episode or whatever. So it's important to know the history, not just at the time you see the patient, but also when you're following them up over time and you see that the disease is progressing despite your pressures being normal. All the important history points that Shalini Mohan brought out are very, very important. And also, as Dr. Shalini mentioned, one thing, when you see a young patient with bilateral acute rise in intraocular pressure with shallow AC, please take the history of systemic drugs that can lead to ciliary effusions like topiramate. These patients will typically tell you that their vision also started to look sudden worsening, and you will find a myopic shift very often in these patients because the lens iris diaphragm moves anteriorly. The age bracket can be variable, but very often there are women more than men at a younger age group. So I think this is a diagnosis where it is really sad if we'll end up doing PIs in these eyes. So this is an extremely vital history to take when you see a bilateral acute angle closure kind of presentation. So I think that was a very important message sent. And more we are learning that intraocular pressure is a causal risk factor, but there are so many other pressure independent factors that can lead to glaucoma and glaucoma progression, whether it is the blood supply to the optic nerve head, whether we are talking about the drug-induced issues or the systemic problems, yoga postures. So there is so much more out there, and it definitely warrants that we take our history from our patients to understand that if they've used steroids in the past, or if there's any other thing that is leading to the change that is causing constant progression despite good intraocular. And of course, compliance in history is very important. That will guide you while you're treating your patients as to how they're using the drugs or not. Maybe they're just putting it when they come to your clinic. So I think we are familiar with all these challenges in glaucoma practice, and a good history can be sometimes really, really important in our clinics. So I think very well covered. So, do you have any questions, any of you, any particular question that you have regarding this?
So I think, Madam, you brought out a very important point on yoga and posture, because so many of us are practicing yoga very regularly, and in fact it is a very good modification in lifestyle also. But sometimes few of the yoga posture, they can lead to Valsalva maneuver, where there is sudden rise in intraocular pressure. And Valsalva just does not happen only with yoga posture. It is in fact happening with many of the things, like if you are blowing some instrument, like you are playing mouth organs, or you are blowing windpipe, that can also lead to Valsalva maneuvers. And especially in patients of glaucoma, this Valsalva maneuver might lead to rise in intraocular pressure. And in fact, we have published a study also in which we did Valsalva on our patients, and there was significant rise in intraocular pressure, and also subsequently there was reduced in ocular perfusion pressure. So this leads to progression of glaucoma, and it has been reported also. So any kind of Valsalva maneuver you have to avoid. Any kind of yoga which is leading to rise in sudden intraocular pressure or rise in intracranial pressure has to be avoided in all patients